Here we talk about developing strategies in the community. Community dietary behavior change interventions can be delivered through whole community actions or individual level approaches, which could include personalized nutrition linked to genetic status. Levels of intervention ranges from regulation, eliminating choice, through to nudging behavior. The Nuffield bioethics ladder and a taxonomy of interventions are available to help explore different levels of intervention. Features of successful community interventions include community capacity building and advocacy. Features of successful individual interventions based on psychological theories include components related to improving self-efficacy, goal setting, self-monitoring, and self-reinforcement. Measuring success can be achieved through randomized controlled trials. Where this is not practical or possible, standard evaluation frameworks exist. The majority of dietary interventions are based on a one-size-fits-all approach. Nutritional genomics allows advice to be tailored to an individual. Personalized individual and nutrition could be based on either genotype, which is the set of genes that a person carries, and a phenotype, which is the individual's characteristics linked to their genotype and environment. Different levels at which public health strategies aim to influence dietary behavior that can be defined and developed within the community. What will be that different level? This includes strategies at the group or population level, such as changes to the physical environment, including nudges, individual approaches, such as the use of social norms in weight loss programs, and personalized nutrition, which can take an individual's genetic predisposition into account. What are groups or population approaches? We start with the theories behind group strategies. As you all know, behavior is affected by a multitude of factors, many of which can be described as environmental factors rather than those attributable to an individual. Dietary behavior is no exception, and the foresight map of the factors affecting the risk of obesity. This map and these factors demonstrate the many areas where we can intervene at a population level, such as in food production and the environment, to improve dietary intake and reduce risk of obesity and other important diet-related non-communicable diseases. Policy makers consider the degree of intervention needed to ensure it is proportionate in terms of how much evidence is available and weighted against the potential financial consequences and interference in people's lives. The ladder of intervention recognizes that doing nothing is an active decision, and this is the first rung of the ladder. Eliminating choices is the highest rung and is reserved for policies where there is strong evidence that the interference is worth it on balance. a ladder you can see here on your screens. This is the new field bioethics ladder of intervention. This concept in the ladder developed to support the designs of public health initiatives and are linked to the degree to which the intervention will have an impact on the individual, either consciously or unconsciously. A taxonomy of different types of intervention has been developed by the House of Lords Science and Technology Select Committee that has been adapted for public health dietary behaviors change intervention. This table has a range of options from regulations with elimination or restriction of choice at one end of the spectrum to choice architecture interventions, including nudges at the other end. A similar approach has been taken by the UK Health Forum, which identified 6 different areas for action when considering dietary behavior change in relation to sugar reduction policies. The 6 themes are set out in a table which you can see here on your screen. These themes begin with producing and importing less, through to recommending less, and ultimately changing what we consume. Dietary factors associated with health outcomes where this type of intervention could be applied include the reduction of trans and saturated fats, free sugars, salt and alcohol. Complex interventions may tackle more than one of these areas of action, while other interventions focus on one particular area. Themes 1 to 4 concentrate on national policy, while community-based interventions target specific subgroups of the population and take place at a regional level. National policies can be mandatory or can be voluntary. Change in national policy can only take place with consistent support across a wide range of stakeholders, including public support. Themes 5 and 6 relate more closely to individual approaches. An example of where regulation has been introduced to improve dietary behavior is the school meal system in England. New food and nutrient standards were introduced by law into all schools in England to reduce intake of poor quality food such as fatty meats, fried foods and sweetened drinks, and to ensure children only had access to good quality food, including fruits and vegetables, and low-fat dairy foods. Published surveys of lunchtime intake have reported improved intake from school meals compared with intakes before standards were introduced, are also compared with packed lunches. Large and legal regulation is not always necessary. Sometimes voluntary codes of practice agreed within the food industry are sufficient to improve health. These are often backed up with the threat of regulation if voluntary action is not sufficient. An example of this is the responsibility deal in England. This has worked successfully with reducing salt consumption by approximately 10% to date. Food manufacturing companies are encouraged to sign up the responsibility deal pledges. Many food manufacturers have signed up and have duly reformulated foods to reduce salt intake across a wide range of foods. Assessment of salt intake using 24-hour urinary sodium measures by the National Diet and Nutrition Service report that adult salt intake reduced from 9.5 grams to 8.6 grams across England. During the same period, blood pressure has also reduced across the country. The impact is likely to be smaller than if regulation had been introduced. Voluntary action can be a useful measure either on its own or as a prerequisite to regulation when more support is needed. Taxes on high-fat or sugar foods have been introduced in different countries in order to change behavior. In the USA, many states have instigated a 10 or 20% tax on sugar-sweetened beverages, with an aim to reduce sales of drinks and ultimately to reduce obesity rate. In 2014, Mexico introduced a levy of 1 peso per liter on sugary drinks, equivalent to a tax of approximately 10%. Evaluation of the levy reported reductions in purchasing and consumption of sugary drinks, but longer-term evaluation is needed to measure reductions in prevalence of obesity. The World Health Organization recommended that countries introduce a 20% sugar-sweetened beverages tax to reduce consumption of sugary drinks and reduce risk of obesity and type 2 diabetes. And this was followed by the action from the British government. A levy on producers and importers is planned for April 2018 in the UK at two different levels. A lower levy for drinks exceeding 5 grams sugar per 100 ml and a heavy levy for drinks exceeding 8 grams sugar per 100 ml. Australia is also considering the introduction of a tax on drinks. Now we have an other terminology which is nudging. What is nudging? The definition of nudging is any aspect of the choice architecture that alters people's behavior in a predictable way without forbidding any option or significantly changing their economic incentives. Improving healthier choices through nudging as opposed to regulation is a relatively new concept. Nudging people in other directions have been used by advertisers and retailers selling confectionery and snacks for many years. For example, the placement of confectionery in more accessible locations in supermarkets, such as checkouts or ends of aisles. Behavior change specialists realize that many of the decisions made that affect health are automatic decisions that use little cognitive capability and are more affected by the environment rather than conscious decisions. Buying the chocolate means that immediate pleasure wins over long-term weight loss goals. Nudging in the right direction has the potential to play a role in improving our health. It means that government can regulate less. Nudging would be found on the new field bioethic ladder on the change default setting rung. This would include making stairs rather than the lift the obvious choice, or making the salad rather than chips the default choice on a menu. Nudging can include providing information on others' healthy behaviors or peer modeling of the behaviors. Our environment is very important for us, and it may be easier to nudge in the wrong direction rather than nudging in the right direction. For example, the immediate pleasure of a chocolate bar placed at the checkout compared with the special offer on fruit. There are some interventions where nudging has been reported to be effective. For example, placing fruit instead of confectionery near the cash register, and serving food on smaller plates and drinks in smaller cups to reduce the portion sizes. There is very little research that has evaluated interventions using the nudging techniques to date. Do you ever think what are the roles of public health nutritionists? Public health nutritionists can play a key role in planning public health programs, either through strategic long-term planning over several years or short-term project management. The aim of most programs is to improve dietary quality and consequently risk of non-communicable diseases in population with the poorest diet, which is determined through a needs assessment. Public health nutritionists working at a national or regional level can be involved in introducing in new regions or populations established programs that have already been developed and evaluated. Public health nutritionists are more likely to be involved at regional and community level rather than nationally. Interventions to change behavior through changing the environment are increasingly complex, and it becomes clear that there are no easy solutions. Group or population approaches to change dietary behavior involve interventions at one or more different points that impact on the availability, accessibility, or desirability of a particular dietary behavior. Government programs have mainly concentrated on providing information which is low on the ladder of intervention and has very little impact. More sophisticated community programs have intervened at a higher level, such as enabling the choice or even restricting choice to increase the chances of improving dietary behaviors. How to develop strategy in a community. Public health strategies to improve dietary behavior tend to be defined as complex intervention. The Medical Research Council has defined a complex intervention as having a range of interacting components. They may have also a number of behaviors targeted for change by those receiving the intervention. The components usually include behaviors, parameters of behaviors, and methods of organizing and delivering those behaviors. It is not easy to precisely define the active ingredients of a complex intervention. Some highly complex interventions, such as the Sure Start intervention, which supports families with young children in deprived communities, is built around a set of individually complex interventions. What makes an intervention complex? Think about it. What are the things which makes an intervention complex? Number of interacting components within the experimental and control interventions. Number and difficulty of behaviors required by those delivering or receiving the intervention. Number of groups or organizational levels targeted by the interventions. Number and variability of outcomes. Degree of flexibility or tailoring of the intervention permitted. New interventions or programs should be based on the most up-to-date available evidence and be tested initially by a full experiment. For large projects, it is useful to have a health education planning model. The National Institute of Health in the USA has a useful resources on making health communication program work, which provides the detail of how planning models have been based in large programs. Community programs targeting children are usually based around schools and less commonly the home environment. Attending schools until late adolescence is a legal requirement for most countries, and school-based research provides an opportunity to target a representative section of this population. Programs aimed at children in low-income families focus on schools in more deprived areas of the country, usually in larger cities. Many school-based programs have successfully improved dietary quality as well as physical activity, but few programs have reported a significant reduction in body mass index compared with control schools. A school curriculum that includes healthy eating, physical activity, and body image, increased sessions for physical activity, and the development of fundamental movement skills throughout the school week. Improvements in nutritional quality of the food supply in schools, environments and cultural practices that support children eating healthier foods and being active throughout each day. Support for teachers and other staff to implement health promotion strategies and activities. Parent support and home activities that encourage children to be more active, eat more nutritious food, and spend less time in screen-based activities. Developing of community programs targeting adults with the aim of reducing obesity is more diverse and more complex than for children. Unlike children, adults may attend a range of places during the day, including working at home. Groups of adults representative of the whole community are more difficult to locate easily for recruitment into programs. Community programs are usually based around a workplace or a community center with a supports, religious or social focus, whereas most of the interventions in children aim to restrict or even eliminate the opportunities to choose poor quality food. The main aim of adult intervention is to facilitate healthy choices. Interventions in the workplace have been reviewed and concluded that worksite interventions achieve modest improvement in weight and BMI in the region of 1.5 kg and 0.5 kg per meter square. Reducing vending machines or increase the exercise facility to help the employees making the healthy choices. Employers can offer vegetables or salad as the default in the canteen so that employees have to ask not to have the vegetables. Other actions employers can make are subsidize healthy food low in fat and sugars and high in vegetables or offering the reward schemes for choosing healthy behaviors. Lowering blood pressure was the main aim rather than the weight loss in some programs. In a community setting, such as worksite with a diverse population of normal, overweight, and obese individuals. Choosing an outcome other than weight can ensure that all employees stay engaged whatever their weight status. High blood pressure has been identified as one of the most important risk factors for CVD, and modest reduction in all, except those with the lowest blood pressure, can improve the health, making it a high priority in many populations. The importance of the food environment on the risk of obesity. Identified important association with the food environment and weight status, but not with dietary behaviors. Weight status may be a stronger indicator of long-term behavior rather than current behavior. For fruit and vegetable consumption, access to supermarkets or takeaways is not associated with the consumption. Greater access to takeaway and less access to supermarkets is associated with higher BMI. Those living in the more deprived neighborhood is more likely to be overweight or obese and less likely to have regular eating patterns. What are the features of successful community programs? Independent impact of the environment on health and obesity risk in communities. Already we have seen councils in England take action to reduce the number of takeaways outlets in some areas. In order to change the environment that we live in and make healthier choices easier, it is important that knowledge and decision making are at least partially in the hands of the community and not just in the hands of specialists in government and health. Always ensuring that this happens is known as capacity building and is likely to increase the effectiveness of community-based programs to tackle obesity or other health outcomes. Capacity building is relatively new in interventions to reduce obesity but is becoming more common. The term capacity building is now included in the World Health Organization Health Promotion Glossary. An example in the EPODE prevention program in France. Most people recognize that there is a childhood obesity, but to bring about change, communities must be able to look at the causes and the solution at a local level in order to design a plan of action. Community leaders need to be identified and the program tailored to the needs of the community. Capacity building effectiveness has not been evaluated, and it is unclear why some programs work and others do not. The Community Capacity Index provides a tool to assess effectiveness in different capacity building domains. Successful behavior change cannot happen without advocacy. Advocacy is a process to overcome structural barriers to change the legislative, fiscal, physical, and social environment in which individuals' knowledge and attitudes are developed and expressed, and in which behavior change can take place. Advocacy needs action from all organizations that are involved with the public health issue, including the media, who provide access to information about those that are making or influencing decisions. Views need to be heard from all sides, including nutrition and medical experts, as well as those who are threatened by policies to reduce obesity in order for effective policies to be planned. I am giving you some examples of community programs. First example is school meal standards in England. What was happened in these standards? Food and nutrients based standards were introduced to schools between 2006 and 2009. These standards were legal requirement for all non-fee paying schools and were included in the quality reports from individual schools. A change of environment gave schools the choice to be academics with more independence. These schools did not have to adhere to the school meal standards. In 2014, the school food plan was produced with new simplified standards that were food-based, not nutrient-based. And what made it happen? The school meal review panel was convened with support from the government in 2005. This panel included representatives from a range of stakeholders in education, catering, and nutrition and produced the food and nutrient-based standards. The school food plan was led by restaurants with input from education, health and catering and introduced to new academics. What was the capacity building? Little community capacity building was planned with the original change in school food policy. Some partners and some parents were against the idea of restricting choices of school meals, and much of this was hyped up in the media. Many school caterers complained that the extensive nutrient standards, 13 nutrients plus energy, were complicated and required complex menu planning and expensive software. Many stakeholders were involved in the production of the school food plan, which built on existing standards and simplified them to ensure users could understand, afford, and follow the new standards. Evaluation of the school food standards found that, compared with 2004, catering provision and lunchtime was healthier. In 2011, foods promoted by the new standards, such as complaints drink, fruit juices, vegetables and salads, water and starchy food, not cooked in oil, were offered more regularly than they had been in 2004. Foods with less healthy nutrient profiles such as condiments, starchy food, cooked in oil, non-permitted drinks, confectioneries and non-permitted snacks were offered less regularly in 2011 compared with 2004. Another example of this include improving the food environment in Wigan, an area with high obesity rates in England. What happened in that? The Healthy People and the Healthy Business Award, run by Wigan Council, aim to improve the nutritional profile of food available to those with very poor diets, including takeaways and care homes. The aims were to reduce salt, eliminate trans fat, reduce the energy density of food, increase fruits and vegetables, and increase fiber intake. 155 businesses were involved in the program over 3 years. What made it happen? Wigan Council was commissioned by the regional NHS to improve the quality of food available to the poorest and hard to reach in the area. The healthy business team worked with other stakeholders, such as the University of Leeds, to reduce the fat content of pies. Businesses were made aware of the marketing advantages of offering healthy foods, which was affordable to the business and the consumer. Local businesses were encouraged to get involved and to change their practices. A range of specialists were involved, including nutritionists and food safety trading standards, food sciences, and catering. Media were published with case studies of businesses that had successfully received the Healthy Business Award and businesses who had increased profiles after they had received the award. What was the outcome of that strategies? Evaluation of a number of businesses taken part in the Healthy Business Award scheme found that revised menus had no impact on consumer choice or cost. Customer choice were close to nutritional guidelines for a single meal. The distinction between community-based and individual approaches may in some cases be a difficult one to make. For example, the school-based approaches may intervene at the whole school level in terms of school meals or policies, or may directly influence the individual child or parent. What is the theory behind individual strategies? There are many different theories which have been developed to support individual dietary behavior change. These come from a range of disciplines including psychology, sociology, and behavioral economics. Each behavioral change theory or model focuses on a range of different factors to explain behavioral change. The health belief model states that individuals change their health-related behavior in response to the perceived severity of the risk to their health. The relapse prevention model promotes longer-term healthy behavior by distinguishing between lapses and relapses to encourage individuals to maintain the healthy lifestyle. The integrated model for motivational and behavioral change is derived from the attitude, social influence, self-efficacy model. This is an integration of the Hudson's theory of planned behavior, Bandura's social cognitive theory, Prochaska's trans-theoretical model, the health belief model, and the goal-setting theories. Elements of these theories such as self-efficacy, which is an individual's belief of their own ability to perform a demanding or challenging task, outcome expectations, self-regulation, goal setting, and attitudes, are common to several of the theories. Social marketing is a further approach that has been applied to dietary behavior. This uses a marketing approach to achieve specific behavioral goals and is the theoretical basis behind the Change for Life program. Change for Life is the first national social marketing campaign to tackle the causes of obesity in England, which started in 2009. Change for Life aims to help families and middle-aged adults make small, sustainable improvements in diet, activity levels, and alcohol consumption. For example, it provides tips to support 5 a day and other Department of Health initiative to increase fruit and vegetable consumption. Social marketing provides a framework for behavioral change and applies techniques from commercial sector marketing. These theories are also used and applied in development of community-based interventions. Maintenance of positive dietary behaviors. Change is challenging. Dietary risk factors and physical inactivity account for 10% of global disability adjusted life years. A high calorie intake associated with overweight and obesity. Intake of saturated fatty acid is strongly associated with increased coronary heart disease incidence and mortality. A high daily intake of fruits and vegetables promotes health. Evaluation of Change for Life found that people struggle to sustain dietary change, particularly in the face of an adverse environment. Improving dietary behaviors and maintaining improved intake is a long-standing challenge for public health. Practical and effective strategies to achieve and maintain positive dietary behaviors for individuals are needed. A systematic review of randomized controlled trials of an intervention would provide the strongest evidence of effectiveness. In order to measure success of behavioral interventions, a standard evaluation framework for dietary, weight management, and physical activity interventions have been developed. The standard evaluation framework aims to describe and explain information to be collected in evaluation of an intervention aiming to improve dietary intake or associated behavior. It is aimed at interventions that work at individual or group level, not at population level. This new approach was necessary due to a lack of high quality evidence on the effectiveness of intervention. A standard evaluation framework provides guidance on the certain areas, which includes how to identify appropriate dietary outcomes for evaluating different types of intervention, how to define suitable measures for different types of dietary outcomes, how to approach the challenges of assessing and measuring dietary intake and diet-related behavior. What are the features of successful individual strategies? Most successful individual diet behavior change or weight loss strategies have a number of particular components. These include self-efficacy strategies, where an individual is supported to believe that they can achieve the desired changes. This can be encouraged by goal setting, aiming to eat an extra portion of fruit per day. All individuals will face barriers to their desired behavior change. These barriers will vary from person to person, but could include concerns about cost, availability, and views of others. Self-monitoring allows individuals to monitor their progress towards their goals on a regular basis. Interventions that combine self-monitoring with at least one and other technique derived from control theory have been shown to be more effective than the other intervention. Dietary intake monitoring has been shown to be effective in relation to weight loss, particularly using a smartphone app such as My Meal Mate. Self-reinforcement of goals and intention is another important aspect relating to individual rewards supporting motivation for change. For example, in long-term weight control, an individual's intrinsic motivations such as enjoyment for regular physical activity, play a more important role than focusing on changes in body weight and diet-related changes. A systematic review of potential mediators of energy balance related behaviors found limited high quality, self-efficacy, and intention may be useful mediator of physical activity. There was also some indication that attitude, knowledge, and habit strength were mediator of dietary behavior intentions. A number of specific behavioral strategies have been recommended for cardiovascular risk factor reduction in the adults in the United States. Cost effectiveness is inevitably also important when considering development and delivery of interventions. There is a range of existing commercial or primary care-led weight reduction programs aimed at the individual. Results of a randomized controlled trial of 6 different weight management programs found that commercially available approaches were more cost-effective and cheaper than primary care-based services led by specialist staff. Recommendations for counseling individuals to promote the dietary and physical activity changes to reduce the CVD risk includes design interventions to target dietary and physical activity behavior with specific and proximal goals. Provide feedback on progress towards goal. Provide strategies for self-monitoring. Establish a plan for frequency and duration of follow-up contacts in accordance with individual needs to assess and reinforce progress towards goal achievement. Utilize motivational interviewing strategies, particularly when an individual is resistant or ambivalent about dietary and behavior changes. Provide for direct or peer-based long-term support and follow-up such as referral to ongoing community-based programs to offset the common occurrence of declining adherence that typically begins at 4 to 6 months in most behavioral change programs. Incorporate strategies to build self-efficacy into the intervention. Use a combination of 2 or more of the above strategies: goal setting, feedback, self-monitoring, follow-up, motivational interviewing, self-efficacy in an intervention. Intervention processes or the delivery strategies include use individual or group-based strategies. Use individual-oriented session to assess whether the individual is in relation to behavior change, to jointly identify the goals for risk reduction or improved cardiovascular health, and to develop a personalized plan to achieve it. Use group session with cognitive behavioral strategies to teach skills to modify the diet and develop a program to provide role modeling and positive observational learning, and to maximize the benefits of peer support and group problem solving. For appropriate target populations, use internet and computer-based programs to target dietary and behavioral changes